Right, welcome back everybody to our last session for the day. I'm Rowena Ironside and I am the chair of the Board of Trustees at the PSP Association. So I will be leading this final session and I'm delighted to kick us off with Professor Graham Martin. So Graham is the Director of Research at this institute in Cambridge, where he leads applied research programs and contributes to the Institute's strategy and development. Dr. Martin's research interests are in the organisation and delivery of healthcare, and particularly the role of professionals, managers, patients, and the public in efforts at organisational change. So how we can improve everyone's experience. So are you with us, Graham? I'll hand over to you.
I'm here, Rowena. Thank you very much, and I will share my screen. Please, if you can't hear me or if there's any interference or anything, let me know. Hopefully you can see the slides. Rowena, sorry,
yes, we can. Thanks.
Excellent. Thank you. I'll get started then because I've got a lot to say and only 10 minutes to say it in. So thank you very much, first of all, for the invitation to join you. I'm going to give you an overview of a study that we at the Healthcare Improvement Studies Institute, this institute, carried out with the assistance of the PSP Association in collaboration with the National Institute for Health and Care Excellence. Thank you very much, the PSP Association, for helping us to recruit to that. And thank you if you were someone who participated in this. This isn't PSP specific, it's looking at planning and delivering high quality treatment and care and decision making around treatment and care at the end of life. But clearly that has resonance, well, for everyone ultimately, and for people with various life limiting conditions. With apologies, I've got to go on the school run right at the end of this presentation, so I won't be able to stick around for the Q&As, but if there are Q&As, I believe Annalise will transmit them to me and I will make sure I respond to them in writing by email. So the background is that people's experiences of planning for end-of-life care and ensuring that the decision-making is effective and inclusive are quite mixed. There's lots and lots of evidence around that. Some conditions, it happens much better than others, but it results in problems like people not having clear plans, sometimes people not knowing they're approaching end of life or how imminent that is, sometimes clinicians who are treating them not being aware that they are in approaching end of life or being aware of preferences they've expressed about the treatment they should receive. There is NICE guidance on this. Very helpfully, Boyd gave a very clear presentation on the role of NICE just now, so I won't re-explain this. But as he said, NICE is responsible for setting standards that healthcare organisations should follow. Many of them do, but unfortunately, there are always problems with implementing these results, and that's certainly true in relation to the NICE guidance around end-of-life care, where, as we see from that evidence above, it's implemented inconsistently and some people have a much better experience than others. So the objectives of this study, which we did with in close collaboration with NICE, was to look at how to try to improve consistency of implementation of these recommendations and guidance around decision making and planning for end-of-life care. So there were three main stages to this study. So we did some interviews to try and scope the area, qualitative interviews. We followed that up with more interviews with people planning for their end-of-life treatment and care, clinicians involved in that, others who are helping them think about end-of-life, and a survey of both healthcare practitioners and people planning for end-of-life care and others close to them. And then the bit that I'll probably focus most on, well, I will focus most on because I've only got limited time, is a consensus building exercise. I'll say a little bit more about what that involved in a minute, but essentially it was trying to look at what needs to be done and what people agree on in terms of the problems and the potentially viable solutions to implementation in this area. We had excellent inputs from a patient and public advisory group and a professional advisory group, including a whole range of stakeholders, and they had a very active input into all the activities. We did this late 2021 to the middle of 2022, and we've just the month before, because we're February now, submitted a report to NICE summarising these findings. It's not in the public domain yet, but in due course we obviously hope to disseminate these findings more widely. And at the end I'll say a little bit more about why we think they might be important and who might be interested in them. Excuse me. So as I say, I will focus in particular on the consensus building exercise, but to run through some of the earlier stages in the research first of all. So our qualitative interviews highlighted some important aspects of the challenge of implementing this kind of guidance, a whole range of things, and I don't have the chance to do them justice, but just to pick up some of the ones that I think were perhaps most interesting. There was certainly a sense that death is something that the healthcare system isn't necessarily that adept at dealing with, and a feeling among clinicians themselves and also among others that sometimes, you know, the healthcare system is there to cure. Going into palliative mode and adjusting to that isn't something that the system as a whole or individual clinicians are necessarily well versed to take, and sometimes that impedes this kind of change of mindset necessary and change of approach to move towards, actually, we've got a different business here now. We want to make sure that we're maximizing quality, that we're respecting someone's wishes and decisions, rather than that we're going all out to cure them at all costs. There are challenges around sharing information between different parts of the system, between health and social care, between different healthcare organizations. And that means that sometimes decision making, particularly in emergency situations, is made without full knowledge of what an individual would like to receive and what they wouldn't like to receive, even if they've previously expressed those preferences. And there's certainly a challenge of knowledge around the legal as well as the ethical issues here, in terms of actually whose decision it is, what assumptions should be made about someone's capacity to make decisions for themselves. And the presumption is of capacity, even if, you know, others disagree or think that they're not making the right decisions. We still respect an individual's choices, and of the status of things like advance decisions to refuse treatment and how they feed into things. So that's just a very quick flavour of some of those issues that make the implementation of this guidance challenging. What can be done about it? Well, a whole range of ideas. I won't go into those in detail now, but those are things that we picked up later on in the consensus building. And just briefly on the survey as well, a couple of questions to highlight from that. A good deal of agreement from both people planning for their end of life and people close to them in red, and health and social care professionals in grey, that you really don't want to leave it until the last minute. And it's really not just a matter of only talking about it if the individual themselves raises it. It is acceptable for others to raise it. Rather, this is the other side to that coin, it's something that can, you know, agreement across all groups here, be raised early on, perhaps when someone is first diagnosed or at the onset of a life-limiting condition, or perhaps even something that is quite reasonable to raise routinely at various points in the life course. And in terms of who is well placed to initiate a conversation about this, again, a widespread agreement amongst professionals and people planning for end of life that actually there's a good range of people who are well placed to do this. Health and social care professionals slightly more positive about some of the scope of some of these groups, but, you know, perhaps a slight preference for people who see you as an individual routinely, such as your GP or another community healthcare team member, but a sense that a wide range of people are well placed to raise this issue. So that's a very brief background on the interviews and the survey data. We use that data then to move into the final stage of the study, which I think is the most interesting and important, and also it had a very, very wide range of participants, a few hundred participants in total, particularly amongst people planning for or thinking about end of life. Excuse me. And the objective here was really to, as I say, build on that data to try to think about what should happen to improve quality of care in this area, and how to make that happen. And really what we wanted to see was how far people agreed on what the nature of the problems were, what the most promising solutions were. Again, we involved people planning for end of life, people close to them, health and social care professionals, and we brought in other groups at this point as well, including policymakers, stakeholders in professional organisations and charities who have an interest in this. And we really wanted to see, was there consensus within groups, across groups, what is most important. So based on those earlier data and with our advisory groups, we developed 13 statements that we put to people and essentially asked them, to what extent do you agree with this? We then had a further round. This is standard Delphi methodology for those who are familiar with it, which allowed people to look at what everyone else was saying, what their peers were saying, what other groups were saying, and if they wished, to adjust their views in light of that. And then a later stage focused in on a few of these issues, particularly around who might best be targeted in terms of any training and empowerment initiatives, what types of skills might be a focus for professional training development, and what might go into a standardized approach to documenting people's end-of-life care preferences. Again, only time for highlights here, but I want to pick out these 3 statements in particular. Of the 13 statements, 11, there was high agreement across all groups on those, and these are 3 of them. I think what is quite interesting here, at least from my perspective, is that it does confirm this notion that actually it's okay for people to raise this, even if they're not necessarily someone who's very familiar with you. Not everyone agreed with that, but lots of people agreed with that. And they also agreed that sometimes, the second question here, raising it at some point, even if it's not the best time, is better than never raising it at all. And similarly, lots of support for this notion that a single system would be desirable. Feasibility, of course, is a different matter, but we'll come on to that shortly. And in terms of the contents of that common system, in the second part of the consensus building, we focus on candidate things that might go into a system like that. All of these were seen as important, which is perhaps not surprising, and it's certainly potentially possible to include all of them. But there were some in particular that received a great deal of support in terms of things that really need to go into a single system, because people need to know about them. People need to be able to access them at various points in decision making at end of life. So final slide, what next? I think what we have here then, thanks to this study, is better knowledge of what the problems are and what people see as important in developing solutions. It's with NICE at the moment, as I say, they're considering it, and it has potential to help them think about what further work is needed to improve the implementation of their guidance and to work with others to develop interventions to improve implementation. It also, as you've seen, sort of sets out ideas about what training needs there are and shows that there's consensus about that and who needs to be trained. It sets out a possible set of things to include in a common documentation system. And more loosely, perhaps a bit softer, but I think equally important, it also demonstrates that actually having these conversations is important to people. So that reticence that we see on the part of clinicians to raise something that's sensitive because of the risk of offending or making a situation worse, I think it suggests that that's an ill-founded assumption, that actually people are keen to have these conversations. They want to talk about it. They know it's a serious thing. They don't want to be infantilized, and talking about it at some point, even if not in the optimal situation, is better than not doing. So it gives a kind of a license to people to say that. But obviously we need to communicate these findings further, which we will do in due course. But that's it for now. Thank you very much for listening.
Thank you, Graham. An excellent summary for us.
And stop share, excuse me, there we go.
Great. So I'm now going to hand over to someone that many of you may know already, because she's been with the PSP Association for 10 years, and that is Carol, our Director of Engagement, who's responsible for the information and support service and also for the PSP's volunteering service. So over to you, Carol. I can't hear you, Carol. I'm not sure whether you're with us.
I'm here. Can you hear me now?
Yes, I can.
Great. Sorry. Thank you, Rowena, and good afternoon, everyone. I'll be talking you through a few of the results of the patient survey we did last year. And if I could have my first slide, please. So we all know how valuable survey data is. It helps ensure we provide the right support for those living with PSP and CVD and their families, as well as providing us with a clear picture of the external environment that enables us to campaign for change and better care for those we support. So a little bit of background before we start. The last time we carried out a major survey of those living with PSP and CVD was 2016. Plans were in place to survey before 2022, but we all know that a pandemic hit and held us up with a lot of plans that we had. So last year, between June and September, the 2022 PSPA patient survey was sent out to every person on our database with a diagnosis of PSP and CVD. People were able to complete the survey online or via post, with the majority completing the postal survey. Those living with PSP or CVD who were unable to complete the survey managed to complete it in partnership with other family members but of course from the patient's perspective. We received just over 400 responses, which was a response rate of 25%, which we were really, really pleased with. Very similar to the 2016 survey. There were 56 questions to answer in the survey, which were quite a few, and some of which were questions asked in the 2016 survey, which has helped us do some benchmarking regarding care, diagnosis, etc. For this session, I'll focus on just a few of the questions today due to time limitation and the fact that we are still analysing a lot of the data that we have. From the survey results, we're producing one overall survey report, followed by 2 follow-up reports, state of diagnosis and state of care. And of course, we will keep you up to date with the progress on those reports through our magazine, PSPA Matters, and our website. So thank you, Annalisa, for the next slide. This slide looks at how long it took for the person's GP to refer them on to a neurologist. The question we asked was, how long was it from when you first consulted your GP, family doctor, until you were referred to a neurologist? The options were less than 1 month, between 1 to 3 months, 3 to 6 months, 6 to 12 months, over a year, can't remember. You will see the 2022 results at the top. There is a positive change here in people being referred when you look at the 2016 comparison. In 2022, 10% of people said it took less than a month before they were referred to the neurologist, which is an improvement on the 2016 data, which shows 13%. This is a similar picture for the 1 to 3 months period, with an improvement from 22% in 2016 to 18% in 2022. If we look at this in terms of actual visits to the GP before being referred to the neurologist, sorry, I don't have a slide for this, but in 2022, 29% of people said they only had 1 visit to the GP before getting a referral, which is a 6% increase from 2016. This is a positive move forward, so hopefully GPs are moving in the right direction. We do still have a lot of work to do raising awareness amongst GPs, and be reassured PSPA are connecting with trainee GPs, as well as continuing our work with established GPs to raise awareness and offer training in both conditions. We hope that since the introduction of our red flag posters, this has also helped. Well, we'd like to think so. Next slide, please. This slide shows how long after being seen by a neurologist, the patient was given a confirmed diagnosis. The question asked was, how long after you first saw a neurologist were you given your confirmed diagnosis of PSP or CBD? Options were less than 3 months, between 3 to 6 months, 6 to 12 months, 1 year, can't remember. I am glad to say we are also moving forward in this direction, but work still needs doing in this area. In 2022, 43% of people received a confirmed diagnosis within 3 months of referral, compared to 35% in 2016. It is, however, disappointing to see that there is no significant change in those having to wait over a year for diagnosis. What the survey did highlight was that people were seeking alternative routes to diagnosis, and that is through private consultations. Next slide, please. This next slide looks at correct diagnosis. The question asked was, which of the following best describes your first diagnosis for the symptoms you were experiencing? Options were incorrectly diagnosed, other, incorrectly diagnosed with Parkinson's disease, currently diagnosed with PSP or CBD. Disappointingly, this data remains the same as data from 2016. Unfortunately, getting a correct diagnosis still remains a challenge. In 2022, 41% received a correct diagnosis compared to 40% in 2016. In 2016, 60% of people received an incorrect diagnosis. Out of that 60%, half were incorrectly diagnosed with Parkinson's disease and half were incorrectly diagnosed with what we classified as other. There is a slight change in 2022, although it's a very similar story. 59% currently, incorrectly, diagnosed. However, we can see an increase of 8% in those being diagnosed with Parkinson's disease, which has reduced the number of people being diagnosed with the classified other. I suppose we could look at this as a positive, as professionals diagnosing are moving in the right direction, but of course we still acknowledge that this is still not good. We know we need more research into diagnosis and treatment into PSP and CBD, and after hearing today about the research that is currently taking place, we are on the right track. The lower part of this slide shows the age of people in relation to incorrect diagnosis, and you will see that the increase in people being incorrectly diagnosed with Parkinson's is across all age ranges. We will be analysing this data more over the next few months and sharing the results with you. We know we still also have a lot of work to do with raising awareness of these conditions amongst health and social care professionals, and this work will form part of our new strategy. Next slide, please. We now move on to coordination of care. Question
Just so you know, Carol, you've got about a minute and a half left.
All right, okay. I won't go into, because you can see what the questions were asked. I will scrap that and just go into the analysis. You will see that 60% of people have a named person that coordinates their care. This is 8% down on the 2016 survey data. This could be down to the pandemic and the ongoing struggles faced by the NHS and the social care that could have impacted on this decline. The plan for us is to talk to our partner organisations to see if they have the same outcomes from surveys they may have carried out. And then we will look at options as to what we can do for campaigning for coordinated care across all regions. Next slide, please. I'm sorry, I'll rush through this quickly now. We've now come to some results on the support PSPA currently offer and also on what people would like us to focus on. And we asked the services that people had used, what had they used and how did they find it? There's not much change here between the 2016 and the 2022 stats. The PSPA method is still as the front runner, followed by the helpline and the website. There's been an increase in those using the support groups, and this is probably down to the variety of support groups we now offer, both virtually and face-to-face. Next slide, please. Making sure our patients and their families are at the heart of what we do is very important to us. And with this in mind, we wanted to know what different functions of PSPA were important to them. So we asked this following question. When we asked this in 2016, next slide, please, sorry. When we asked this in 2016, the front runner was providing support to people affected by PSP and CBD. In 2022, people's priorities have changed slightly, and now 53% of people living with PSP and CBD would like our focus to be on increasing levels of awareness and knowledge amongst health and social care professionals. This is understandable when you look at the survey results relating to the time it takes for people to get a referral to a neurologist and receive a confirmed diagnosis. When we launch our three-year strategy in the coming weeks, you will see we have listened and we will work to ensure that people with PSP and CBD receive support that is coordinated, has continuity and is compassionate. I would like to finish by saying thank you to all those people with PSP and CBD who completed the survey, and also to James Noble, PSPA trustee and associate director at MPC, for helping us with the survey. Thank you for listening. And I'm sorry I went over time.
Thank you, Carol. Right, so our final speaker today is a slightly newer member of the PSPA team. She is our research coordinator, Annalisa Castron. She's done a lot of the work in organizing today's event, ensuring we've had so many fabulous speakers, as well as being research coordinator at the PSP Association. Annalisa is also a senior research fellow at the University of Hertfordshire's Health Research Methods Unit, and an advisor for the National Institute of Health Research. So over to you, Annalisa.
Thank you. So good afternoon, everybody, and thank you for holding on until now. I know it's been a long day. In the next 10 minutes, I would like to explain what is PRIM, the PSPA Research Involvement Members Group. I'm grateful also to Liz, who will be joining me in this presentation. So the research process follows a well set out path, and that is sometimes quite complicated to navigate, but it's been established to protect the public. So people that participate in the research studies are treated with respect, are safe, and they feel are making a difference. So research starts from an idea, and around that idea, a study needs to be designed. So funding is needed to conduct a study because there are expenses related to several items. Research costs include staff salaries, facilities, drugs, device costs, research materials, patient travels for visits, sample collection and processing, storage, analysis of data, publishing and dissemination of results. So researchers need to apply for funding and develop research proposals. When they are successful in obtaining funding, they can undertake the study, then analyze the data, disseminate the results. They need to evaluate the impact of their work and then monitor what happens when the results are embedded into practice. Then other ideas come from the changes made and the cycle starts again. It is important to involve the public into the research cycle because the topics for research are identified with the patient benefit in mind, and patients should be asked if the questions are meaningful for them. So patients, carers, families, professionals, and healthy people do have a voice and can be involved in the research process, and they can be supportive in each of this section of the cycle.
Annalisa, your slides are quite small. I'm not sure if it's the way you're displaying them, but that last one, it was hard to read. Okay,
but this should be better. What PSPA is doing to ensure people are heard, sorry, is asking them what they need. Like we did with the patient survey, we organized a service committee to identify priorities. Then we ask continuous feedback via the helpline and local groups and involve patients and carers in research. There are three ways in which the public can be linked with research: be a participant, so being asked to take a new drug, for example, or be part of Prospect, PIPIN, or the other studies we heard today. People can be engaged, receiving information about research results, or be involved. That means when there is an active partnership between members of the public and researchers, and I will explain this later. Those involved in research help researchers to ask their question better. So in July, we started a new group that is called PSPA Research Involvement Members. We have 7 volunteers who are all carers or ex-carers of people affected by PSP and CBD, and we meet monthly. We discuss research studies, identify the questions that patients and carers would like answered, and can become priorities for research. 2 members were involved in a drug development process and all helped reviewing research proposals. They gave input on public-facing materials like the new research leaflet and the program of this event. And also I like to think that we do support each other when we share experiences and tips. So now I will ask Liz to say a few words about her experience of being part of this group. Liz, are you there?
Hi, Yes, I am here. I don't know if you can see me.
Thank you. Yes, and hear you.
Okay.
Thank you for coming.
Okay, so I've been part of the PRIM group since last summer, and my husband had CBD. So I've really enjoyed being part of the group. I think it's been so valuable, and it's been such a support, because as everybody I think knows, being a carer for somebody with these conditions, being part of the family is quite a lonely and isolating and can be quite confusing place to be. So I think it's been a really valuable experience for me, and I've done the sorts of things that you've described. So I've been part of the regular monthly meetings, which again we support each other, and there are people with a variety of different experiences on them. I've been an observer at research meetings. I've been involved in reviewing the agenda, for example, for today, looked at research proposals, but always I'm looking at it from the perspective of the family, or the family. And I think that's what's really, really valuable for everybody. And so I've really enjoyed the research day today, which has been great. And it's one of the things I think about from a family perspective is when we hear about research, we've all got our own experiences of the reality of actually going to the research, taking part in the research, and the issues and the positive effects of that. So it's been a really great experience, and I've really enjoyed it and found it valuable. And I always ask at the end of everything, what about CBD? Because it's one of my things is making sure that CBD has a voice.
Definitely. Thank you. Thanks a lot. So I finished quickly. So we are here basically to say that if you want to get involved in research, we are keen to give patients and carers a voice. So to help shape research projects from the beginning and ensure PSPA funded research reflects the views of its members. This will enable patients to participate in clinical trials and other research studies. So if you are interested, please contact me using the address. Also, we have a specific form on the website, can be requested through the helpline in paper form to express the interest of being a study participant, be engaged, or be fully involved. Thank you.
Thank you, Annalisa, and thank you again for all your work in putting today together. I will hand over to Rebecca shortly, because we don't actually have any specific questions for this group at this stage, but just to say that if any of you are worried that you didn't pick up on an email address or anything, you can always contact the helpline at the PSP Association to follow up on anything that's come out of today. So thank you all for attending. I'll hand you now back to Rebecca.
Good afternoon. That just come up. Hang on a moment. Yes. Afternoon. Thank you very much for sticking with us for what's been a really fascinating day, all the way from cutting edge artificial intelligence information through to those very practical trials that are happening in clinics, and how we might influence the standard of care and supports that people get through things like NICE guidelines. I think it's highlighted how important partnerships are, the way we've brought so many people together today, and that we can see how people are working across the country. I'm delighted that later in the year we'll be trying to bring those clinicians together again across the world in an international symposium, which we'll be organising jointly with Cure PSP in America. And that's really important that we continue to join the dots for everybody and make progress. I think it'll have given the team at PSPA a lot to think about today. Clearly had a lot of questions, and we've already been chatting offline about how else we can ensure that you get those questions answered, not just for today, but sort of more on an ongoing basis, if we should be making some more podcasts or short films where you can see the more common types of questions answered. So we'll definitely put our minds to that over the coming weeks. I do want to say thank you to all of the speakers who have been here today. I know that they're all really busy, and giving up your time to speak to the PSP and CBD community is really important. And to all of the team that have helped organise today, who have been clicking away, admitting people in copying the questions, so we've got them online for later, and for Annalisa, who's really done a sterling job in her first conference as our research coordinator. We've got a short poll, just 3 questions for you to answer about the day. We will send out a more detailed evaluation. So that's up in front of you now, hopefully for most of you. You can see that. So you should be able to click the answers to those questions. Yes, people are starting to answer those. They're coming up online. You haven't had your detailed answers to your questions yet today. We will be making sure we get all of those answered and sending those to people. I think we've had about half of the people currently attending answered questions. I know a lot of people have been in and out today, so we will catch up for those not here by sending that out as well. Just give people a little bit longer to answer. So it looks from the results at the moment that generally people are satisfied and have found this useful. It's important for us to follow up and make sure that you continue to get the answers that you need. And just to say that, you know, some of the points you've raised are exactly what we've been discussing in the team about the need to raise awareness, that we don't have the same profile for PSP and CBD that there are for things like motor neurones disease. So we are putting plans in place for the Awareness Week this year and really starting to try and improve that so that we're able to get more funding for research. We're able to ensure that GPs are more likely to recognise symptoms and can refer people to neurologists. We know that that's all really critical. So thank you very much for staying with us and for contributing to the day. And you may leave the room if you want to.